Hello, everyone. It's 3 p.m. Here in Innsbruck, Austria, and let's start as scheduled as we have participants from all over the world from different time zone, and we need to respect their obligation. My name is Dr. Anandhan Dhanasingh, and currently I'm serving as the head of Translational Science Communication within Research and Development Department at MED-EL headquarters. And together with my colleagues here in the studio, Ms. Christina Meyer and Anna Deem, we would like to welcome you all officially to this episode of Surgery Online webinar series. And I'll be your moderator for today. And we will be watching cochlear implantation surgery in common cavity deformity. Before we go into the topic, let me give some tips to our participants. Please name yourself and from where you are from, and that will help us to identify who you are during the question and answer session. And talking about the questions, please feel free to type in your questions whenever things aren't clear for you. And also more questions you ask, more interesting this session will become. And please mute your microphone if you are not speaking. And if possible, please close all the programs, and that will help you to watch the video without any interruption. Christina, could you please switch on the top camera, please? Before we go on to introduce our speaker for today, let me take a few minutes to introduce what the topic is for today. In the normal anatomy in a ear, where the cochlear portion is very well defined, and placing an electrode inside the cochlea to cover the entire frequency range is pretty straightforward following the surgical procedure. However, in a severe malformed cochlear condition like the cavity type malformation, what you see here, where the cochlear portion is not well defined. And in such cases, how to approach the inner ear for the placement of the electrode, and what could be the surgical complications during the electrode placement and also after the CA surgery. They all are questions. And to find an answer, we will listen today to Professor Yongxin Li. Could you please have the slides, please, here? And we will listen to Professor Yongxin Li from China. And he is the head of the ENT department. Could you please? He's head of the ENT department in Beijing Tongren Hospital from China. And together with his colleagues, he has performed more than 5,000 CA surgeries, and that includes more than 80 common cavity CA surgeries. And he has written more than 60 research articles. And on top of that, he has written and edited a book recently on cochlear implantation for common cavity deformity. And in this book, I had the honor of writing 3 chapters, and it was a wonderful opportunity and experience to collaborate with him and with his colleagues. And I'm equally excited, like you all, to listen to what Professor Yongxin Li has to show in this episode. And Professor Li, please take over from here.
Hello, Dr. Ananda. Thank you for introducing me. Yes. Can you hear me, Dr.
Very well, sir. Very well. I can hear you very well.
Thank you. Thank you for inviting me to share my experiences with international doctors. I have the great honor to do this. Thank you so much. Also, today my topic is common cavity cochlear implant for common cavity deformity. Our hospital was established in 1886. It is a general hospital which focuses on ophthalmology and otolaryngology. It actually is an ENT special hospital. So long history. Yeah, so let's see cochlear implant in Beijing Tongren Hospital. So the first case for cochlear implant in China, the time is 1996 in our hospital. So from 1996 to To now, almost more than 5,000 cases were done in our hospital. And the special is more than 1,700 cases were inner ear malformations. And the proportion is increasing. And you can see this. So too many inner ear malformations in China. So in 2006, in our hospital, we preferred the minimal incision access and flight protection. So the incision, 30 millimeters long incision, you can see this is we use the skin protector to make the incision smaller and smaller. So this is a flap protector. We designed this. So this is a patent from China government. So during the surgery, we use this skin protector can make the incision become smaller and smaller and easy to explode the bone bed and easy to do the surgery. And also in China, the parents prefer the small incision technique compared with a large incision technique. And you can see, not easy to find the incision post-surgery. You can see all the cases were done with MED-EL devices. Very small incision technique. You can see, very good. Yes, let's see the common cavity. So at the fourth week of embryonic development, auditory vessels stopped developing and result in severe deformity. Actually, we found 5% of them suffered from congenital sensory hearing loss. Why the common cavity for cochlear implant not easy? Because too much complications are easy to occur. The main complications is facial nerve paralysis. And this facial nerve paralysis also can cause the CSF leakage. Also for the electrode very easy to enter the internal auditory canal. Also some case after surgery, the patient easy to cause the meningitis. So for this kind of reason, the common cavity sometimes not easy to do. So for common cavity surgery, what kind of surgical approach should be okay? And what kind of electrode area design should be suitable for common cavity? So let's see the literature for the surgical approach. In 1986, the doctor used mastoidectomy approach like this. And in 1995, canal wall down technique was used. And also in 2000, let's see this, in 2005, the doctor used double posterior laparoscopectomy approach. This is very common used. In 2013, the single slit cochlear approach were used. But in our center, we try to find another surgical approach for this kind of case. So we prefer the slot laparoscopectomy approach. Let's see the approach. So this is a common cavity. This is internal auditory canal. We put a single slot was made to which the place that we can open this. This place just similar with the normal structures, lateral semicircular canal. So we open this slot and put the customer electrode enter the common cavity. So you can see we put inside this just like this. So this is internal auditory canal, and this is the electrode. We put like this. Then we put a muscle and fascia inside this. So from this photo, we can see the cavity was filled with muscle to force the electrode against the outside wall, because we know the ganglion cells just among this wall. So the electrode should be against the wall tightly. Then the results much better than the former technique. Let's see the customer electrode. This was designed by MED-EL company, and this is why this part belongs to the electrode. So this is easy to enter the cavity. So doctor can put this, insert this. Let's see the surgical video. So we prefer the small incision technique, almost 30 millimeters long. Put this. And this is a fly. I try to make it bad for the receiver. So from now we use the skin protector to open this, and under this we can drill the bed. You can see the bed, and not easy to cause the flap injury because use this skin protector. 是不是？我觉得这个网还是有点卡，是吧？So we made the bed first. After this, we opened the mastoid. We opened the mastoid just like this. Yeah. So for this, because this very young kids, the mastoid are not very big. Try to open the mastoid to make the entrance clearly to see. For the severe inner ear malformation, the mastoid is easy to open. But after we open the mastoid, we found the entrance. Then we try to locate where is the place for the common cavity. I'm not sure the internet is okay. Okay, yeah. So for this kind of surgery, we should not try to open to make the mastoid explode too big. For the inks, we should not open the inks. So some patient, the patient has the residual hearing. We cannot make the inks damaged. So we try to preserve the hearing. Yeah, from here, we try to locate, for example, if this is a normal cochlear structure, we try to find the normal anatomy. We try to find the semicircular canal, lateral semicircular canal. Just similar with the lateral semicircular canal, we try to locate the common cavity. Now we try to skeleton the common cavity. Remove the bone area. So we used a diamond driller. Skeleton the common cavity, just like a lateral semicircular canal, we made some blue line, try to open the cavity. Yeah, this is a cavity. So we remove the L cells. Oh, okay. Yeah. Yes. So yes. So we open the bone structure for the common cavity. We remove the bone. So made a slot here to open the common cavity. Yeah, like this. Then we put sterols among the common cavity, inside the common cavity. Yeah, this is sterol. Then we put the cochlear into the bed.它不是完全匹配是吧？哦。我这可以继续，我说这儿说那儿。So you can see it here. Yeah, we try to insert the electrode. So the electrode, just this part. So we put the electrode inside the cavity. This is electrode is formed electrode. Yeah, put inside the electrode. So this is the wire. Well, the middle part electrode. Then we put a small piece of muscle and fascia inside the cavity. We try to make the electrode against the outside wall. So we put a piece of muscle inside the cavity. Sometimes the common cavity can combine with the CSF leakage. So the muscle should be put tightly inside the cavity. Mm. 我不看那个啊。 这个。时间来得及是吧，数值？那就怎么着？这个录像要放30分钟是吗？啊，那我还用快进吗？So we put muscle inside the cavity, then can fix the electrode. So we stopped. So we try to locate the Y inside the mastoid. No tension. This is Jiafeng. Is that? Yeah, just all. Okay, so the surgery video is stopped. After surgery, let's see the electrode image. You can see this is here the electrode. This electrode like this. You can see here, and also different cases from common cavity. You can see the electrode against the wall. Also, this is a small cavity, and this is also small cavity. So for the traditional straight electrode, put inside this, just this part, you see. But for the customer, the design electrode, can like this. So the ganglion cell just around the outside wall. So the electrode against the wall and face the very good. But for this traditional electrode like this. Recent years, our team published the 3 papers and also 1 book, Cochlear Implantation for Common Cavity, was published. So recent years, our team did like something like this. What kind of character is for mapping? Let's see. The 2 groups just like this. One just like this, another one like this. We named this middle curved group because this is low MCL and short distance to cavity wall. And also this group, the results much better than this group. Later, I will let you know what kind of reason that caused this. Also, our team, we follow this kind of patients for a long time. You can see 48 months and 60 months. So 5 or 6 years followed up. Let's see, this is CEP score. You can see 5 years later, almost reached 7 scores. And this is SIR scores. You can see at the beginning like this, 5 years or 6 years like this, almost near the 5 scores. And this is a maze. This is mice. And you can see here maze, also after surgery, 1 month, 3 months, 6 months, and 6 years, almost 50. So for these mice, you can see 1 month, 3 months, 6 months, 80, 48 months, 60 months, almost like this. So for this kind of case, the progress is not so quick. It means need long time for them to get the high scores compared with the normal cochlear structure groups. This case was done in our hospital. So today I just finished my talk. Thanks for listening. Thanks, Dr. Alanda.
Thank you, sir. That was a complete package covering every aspect of CI surgery in this difficult inner ear anatomy. And before we go on to address the questions from the audience, I got a couple of questions if I can ask first. My first question is that, like in your initial slides, you showed that the percentage of patients with inner ear malformation is getting increasing over time in China. Could you please explain us why this is the case in China, that the number of patients with inner ear malformation is getting increased over time?
I can answer your question now.
Yes, sir, please.
Okay, thank you. Thank you for question. Because in China is a developing countries, especially for the rural area. The population is very huge, and the health care, the birth care, sometimes not very good compared with Beijing or Shanghai big city. So this kind of case is very common, very common. So too many these kind of cases, much higher than European countries or United States. So I think also in India, maybe the same thing with China.
Maybe, yeah.
Mm.
Thank you.
Thank you.
My other question is that, like in the video, you have shown that after you place the electrode inside the cavity, you fill the cavity with the muscle tissue. My question is that, like during the reimplantation surgeries, while you explant the electrode, will this muscle tissue cause any complication?
Thank you. This is a very good question. We did this kind of cases. We open the cavity, pull back the muscle, no problems. The muscle still there, muscle, and the electrode take back. Everything is good and easy to reimplantation. No any kind of complications. Because for this kind of case, we not open the facial nerve philosophies and everything to see clearly. So no any kind of complications for this case during the second surgery.
Good to know, sir. I think it's time to look at the audience question, if there are any. So Anna, could you please? Yeah, participants. Yeah, so there is one question. Yeah, so it's my colleague Fabrice. He's asking that question. So in this custom-made device, now there is this silicone extension, right? And after you place the electrode, will you cut that silicone extension, or you will leave the silicone extension as it is?
Thank you. It depends. For very young kids, if the mastoid is too small, not very big space, we have to cut the wires.
I see.
But for the mastoid is enough space, we just put inside the mastoid. It depends the size of the mastoid.
Okay, sir. So depending on the size of the mastoid, you will decide whether to cut that silicone extension or leave it in place. I understand.
Yes,
that.
it depends.
All right, sir. Thank you. Thank you. And yeah, so is there any other question from the audience today? Yeah, so it's from another colleague of mine, Florian. And he asked, do you also see less risk of ending up in the vestibular portion with this technique? You also see, Florian, is your question related to placing the electrode in the vestibular part of the cavity? Is that, did I understand it correct?
Okay. Hi. Yeah. Maybe it's easier just to
That would be good, please.
Directly. Yeah. With other techniques, sometimes I saw that semicircular canal is used to insert the electrode because some apparently landmarks are not always very clear. And to have better guidance, a semicircular canal is used to just insert the electrode in this cavity structure. And one challenge is then to distinguish which electrodes are actually in the vestibular portion of this cavity structure and which electrodes are then in the cochlear structure or this cochlear part of this, yeah, cavity-like structure. And with this technique, as far as I saw from the video, you don't really go via any vestibular duct, but directly create this this line-shaped incision or this enlarged incision where you just enter or push in this loop of the foam electrode.
Thank you. Yes, because for the common cavity, this is just like a curve. For the normal mastoidectomy, normal cochlear structure, we know where is the lateral semicircular canal, where is the posterior semicircular canal for the normal structure. But for the common cavity, there's only a big cavity there, no any kind of structure at all. So we try to open the blue line to make sure this is a cavity. Then we make a very tiny slot to see is there the common cavity. Sometimes we met this kind of situation. The two cavity, very small, actually is a big hair cells, is not cavity. So easy to cause the confused doctor. So we make sure the big cavity is a common cavity. Then we put inside the electrode because no other space, no other place to enter. This is only one cavity. So I think it doesn't matter. We met this kind of case for the common cavity. Sometimes the bone structure, put inside some bone structure, just the maybe near future, it belongs to lateral semicircular canal. Also the bone structure inside the lateral semicircular canal. We remove the bone structure to make sure clearly, then put inside electrode. Do I see clearly, Dr. Ananda? Thank
Yes,
you.
sir, it was very clear. Florian, I hope it answered your question. Moving on to the next question from Mr. Nauf Akhil. He asks whether you have any experience with any electrode trauma where you had to turn off one or two contacts.
Oh, yeah. I see, I understand. So we put inside the electrode subtly. We do not touch the electrode. We sometimes hold the wire inside. Put the electrode inside the common cavity. Then we put piece of muscle inside, not cause the electrode trauma. We know the electrode there. We put the muscle here, not straight force the electrode. We put muscle here near the electrode. So from this way, we try to avoid electrode trauma.
So
Thank
from
you.
your experience or in your practice, you have not had any wire breakage. Can we understand it that way?
Yeah, sure.
Okay, sir.
No. Yeah.
Thank you. More questions from the audience or? Yeah, I don't see any more questions. If that is the case, I would like to thank our participants and our guest speaker for their active contribution and for their participation in this webinar. And I would like to sincerely thank you all for your participation. And okay, so there is one question coming up. Maybe one last question. Yeah. So do you make any measurements like art measurement in these cases?
Measurement art?
Art.
Yeah. It is very good question. We did. But for this kind of a case, routinely for me to do this kind of surgery, for the surgery, I think lasted 30 minutes is enough. But for the NRT test, maybe double times measurement for this. Why? Because for the inner ear malformation, severe inner ear malformation, not easy to find the ABR wave, not easy to detect this. So we use when we test this before we enter the electrode, we use a special test electrode to put inside around the internal auditory canal part. This part, is there any kind of NRT or ABR? This we will try to so many times. So it lasted a long time. It takes much more time to test this. But fortunately, only among the internal auditory canal, this part, easy to find the wave. So maybe I also have a question for you, Dr. Ananda.
Yes,
maybe near future, you should design special electrode, only focus around the internal auditory part. In this part, I think much more ganglion cells there.
Yes, sir. Yes. Because that's where the nerve fibers comes and then sprouts out. And yeah, so I can understand that. Yes, thank you.
Yes. So this part easy to find the EABR wave, but for near far from this part, not easy to find the wave.
I see.
Maybe in near future, around the internal auditory canal, this part belongs to Cochlear, and the far belongs to vestibular
function.
system. Yeah,
maybe makes sense. So thank you very much for your time once again, sharing your experience with our audience today. I think we had around about 60 participants who were online, and the whole session is recorded. So whoever didn't find time to be online, they will be listening to the recording later. I think it was a wonderful show we had today. Thank you for sharing your experience, because this kind of difficult CA surgeries, the young surgeons from the other part of the world, they did not have that chance to look at it. And I think you did very well to share your experience. And I'm sure all our participants would have gained a new knowledge from this webinar. Thank you very much, sir.
Thank you, Dr. Ananda. Thank you for your team. Also, thanks for your team.
Thank you,
because
sir.
prepare this, organize this meeting not easy. Thank you.
That's correct. That's correct. Yeah. Our
Thank
colleagues
you.
from MED-EL China and my colleagues here in the studio, so they made it possible. It's a great success. Thank you.
Yeah, thank you. Have a nice day.
Thank you, sir. You too. Take care.